Good afternoon, everyone, and welcome to the first Yale Pulmonary Critical Care and Sleep Medicine Grand Rounds of the 2024 fall season, and a special warm welcome to all our applicants to our Pulmonary Critical Care Fellowship Program visiting us virtually today. My name is Clara Yagi. I'm on faculty in the section of Pulmonary Critical Care, and I have the honor of introducing our first speaker. So we are starting out with a bang this year with one of our very own third-year fellows, Dr. Madelyn Renzetti. And if you have ever had the pleasure of working with Maddie in the ICU or the pulmonary consult service, you know her to be a deeply caring clinician and an outstanding educator. Most notably, I think, during her morning whiteboard talks to the house staff before rounds in the ICU, where she does impressively deep dives into complex physiology and makes this very accessible. And on rounds, she has become known in our section for her clinical aphorisms, my favorite one of which is, and please say this with me, Maddie, dry lungs are happy lungs. Exactly. Dr. Renzetti did her undergraduate work at Colby College, her medical degree at the Lewis Katz School of Medicine at Temple University in Philadelphia, and her internal medicine internship and residency at Weill Cornell. We were fortunate to recruit her here to Yale for her pulmonary and critical care medicine fellowship, where she is concurrently obtaining a master's in health science via the medical education degree pathway, and is doing a thesis focused on the development and validation of an assessment tool for competency in teaching point-of-care ultrasound to novice learners utilizing peer and near-peer educators. And today, she will be discussing another topic of great interest and importance to critical care medicine. And her talk is entitled The Intensivist Guide to Substance Use Disorder Treatment, Bias, and Combating Stigma. So welcome to the podium, Maddie.
Hi, friends. Thank you for that introduction, Dr. Yagi. Welcome everyone to the first grand rounds of the year. And special thank you to Dr. Donroe, my mentor for this talk, for coming in person and helping me out. Special welcome to our interviewees. I got to meet some of you, and as I said earlier, I can't tell which of you logged in, so I can't hold it against any of you. So let's get started. First comes first, I have nothing to disclose, but you all can get CME credits if you act fast enough. So I want to start with a case that sent me down a rabbit hole trying to understand how we as individuals and the health system treat patients with substance use disorder and the profound consequences this treatment, both the good and the bad, has on this population. The following case is a true story from when I was a fourth-year sub-intern at Temple University. The story reflects hospital policies and procedures that are over 5 years old, and Mr. H was one of my first patients on this rotation. So Mr. H is a 35-year-old man with opiate use disorder in remission with prior IV drug use who presented to the ED with progressive right hip pain and right lower extremity pain. Blood cultures come back with gram-positive cocci chains. Ortho evaluates him for septic arthritis, takes him for right hip washout, cultures from the hip also grow gram-positive cocci chains. They speciate to group A strep. IG evaluates the patient. They recommend 4 weeks of IV antibiotics. Mr. H is currently living with a friend, but he has family he can stay with after discharge. He's not currently working, but he's previously been employed as a car mechanic. Hospital policy states that patients with a history of substance use disorder cannot be discharged home to complete IV antibiotics. Only 2 skilled nursing facilities actually accept patients with a history of prior IV drug use. The only accepting SNF is on the same block that Mr. H had previously purchased heroin. He's afraid that if he's so close to this spot, he will return to active drug use. He defers admission to the SNF, instead asks for a patient-directed discharge. PICC lines pulled, he's prescribed an oral antibiotic regimen in place of the IV antibiotics, and he's sent on his way. And I'm sure we've all come across a Mr. H in our time as physicians. After all, PICCs are a requirement for most OPAT programs. But clinicians commonly require people with PICC lines who use drugs be discharged to nursing facilities, or they avoid use of PICCs altogether and keep the patient in hospital for duration of treatment. This results in prolonged hospitalizations for people who use drugs, placing them at increased risk of hospital-related infections, increasing the likelihood of patient-directed discharges, and as we saw in the case of Mr. H. Summarily, avoiding PICCs among people who use drugs strips them of their autonomy and shared decision-making and compromises the standard of care and further stigmatizes their drug use. There it is. So I was deeply upset by Mr. H's case, but I came to accept that this was the reality that this patient population faced because, I mean, the alternative must be unsafe. Imagine my surprise when 2 years later I saw this headline. Turns out in 2018, the Infectious Disease Society of America, the same year that I met Mr. H, concluded that the evidence was insufficient to support or refute home-based OPAT for patients who currently or previously used IV drugs. The NPR article described a team at Brigham who ran the Bridge Clinic, a walk-in clinic for patients seeking treatment for substance use disorder. In 2018, the clinic started a program to get patients with a history of substance use disorder home to complete their antibiotic course. They settled on 3 requirements. First, patients would need to be already on or willing to start medication for their substance use. Second, patients would need weekly check-ins at the clinic. And third, they would need to have stable housing and a sober person to live with. The pilot program enrolled 40 patients, 21 of whom were still actively using drugs at the time of enrollment. All 21 of these patients successfully completed their antibiotic courses without complication, and only 3 returned to active drug use, but they did not use their PICC line to do so. As Stephen Connolly, shown on the right, put it, if I want to get high, I know how to do it. I'm not going to mess with a PICC. 2 years later, after I read that headline, the New England Journal of Medicine published this opinion piece. The article described a study that compared patients who inject drugs who are discharged with a PICC versus those who remained in the hospital to complete treatment. The study showed that there was a higher incidence of line infections for patients who remained hospitalized, and less than a third of them were offered treatment for their substance use disorder while they were in the hospital. A separate study in this population showed that patients were more likely to complete antibiotic therapy if they were home, though obviously there's risk of bias because these patients were determined to be good candidates to go home on IV antibiotics. But the article ended with, instead of asking whether we can discharge the patient with a PICC, we should ask ourselves, have I done everything I can to safely discharge my patient with gold standard treatment? I mentioned that case in my resulting rabbit hole because it was the first time I witnessed the stigma against this population, and I had taken care of someone who had the stigma baked into the medical system and it harmed him. His substance use was in remission, and he was proud of that. He had sober people to stay with. And if he had lived in Boston, he might have been allowed to go home to complete his antibiotics in peace. And instead, he left without gold standard therapy because he was afraid that our hospital policy would destroy his sobriety. So obviously, there's things that we cannot control, such as hospital policies. So I want to talk about the things that we can control to improve the lives of patients with substance use disorders. So my objectives today, we're going to discuss the medical management of critically ill patients with substance use disorders, discuss bias in this population, the impact on this population's care and their outcomes, and then discuss strategies to combat implicit and explicit bias against this population. And then I quickly realized that I might have bitten off more than I can chew with this objective. So I have a few disclaimers before I start. This is a massive topic. I did not cover everything, but I really like QR codes. I made a bunch of them. I really hope you guys use them for your own reference. So let's start simply. What is substance use disorder? The DSM-5 criteria are used to diagnose substance use disorder, and it involves patterns of symptoms caused by using substance that an individual continues despite its negative consequences. This includes 4 basic categories: impaired control, physical dependence, social problems, and risky use associated with their substance use. Substance use alone is not a diagnosis of substance use disorder. The two should not be conflated. Inappropriate use and overuse of substance use disorder undermines the meaning of the term and the seriousness of the medical condition. Now let's talk about the stakes. Substance use disorders, including misuse of alcohol, opiates, and stimulants, are present in up to 23% of the patients that we admit to the ICU in the United States. This is due in part to the association between substance use and the development of multiple conditions requiring critical care. For example, substance use is a risk factor for hospitalization for DKI, and there's longer subsequent ICU stays for patients who have substance use disorder as opposed to those who do not. In addition, substance use is associated with injury and trauma, including motor vehicle accidents, falls, drownings, thermal injury, homicide, and suicide. In the United States, up to half the trauma beds are occupied by patients who are involved in alcohol-related traffic accidents. Outcomes of critical illness are generally worse for hospitalized patients with versus without substance use disorders. This population is significantly younger. Median age is about 44 by some estimates, and they have less organ dysfunction than comparator populations in the hospital, but they have similar rates of invasive interventions and higher in-hospital mortality. But in patients who are not already plugged in with addiction medicine services, ICU admission can be a pivotal moment for patients with substance use disorders, serving both as a motivator to change, as well as an opportunity to connect with addiction services. There's an increasing number of hospitalizations for overdose in persons with opiate use disorder and intoxication with designer drugs, such as synthetic cannabinoids and synthetic cathinones, which we know as bath salts, and MDMA. Management of critically ill or injured patients who use illicit substances is complicated both by the intoxicating and the withdrawal effects of those substances. In general, when we encounter this patient population, we will manage one or a combination of overdose, agitation, withdrawal, and iatrogenic dependence, but I want to make special mention right now of iatrogenic dependence. As we've all seen, patients frequently require opiate infusions during mechanical ventilation, especially if neuromuscular blockade is required. This can lead to high cumulative opiate doses, especially when patients are mechanically ventilated for an extended period. When these infusions are stopped abruptly, these patients can experience iatrogenic withdrawal, potentially resulting in longer durations of mechanical ventilation. The presence of physiologic dependence alone does not mean that this patient has substance use disorder. However, it's prudent that we identify these patients and treat their dependence and withdrawal appropriately. Speaking of, I want to take a moment to drill down on the importance of appropriate management of agitation and withdrawal in this population. In patients with substance use disorders, the important focus on pain and delirium in the ICU that we give all of our patients is extended to include recognition and management of withdrawal. Addiction, withdrawal, and delirium are powerfully and reciprocally linked. It drives patient experiences and clinical outcomes. Untreated or undertreated pain and withdrawal in this population leads to a negative feedback loop that promotes drug craving, damaged trust in providers and medical systems, patient-directed discharges, and missed opportunities to benefit from life-saving substance use disorder care. And it creates the perfect conditions for delirium. In all ICU patients, delirium has terrible and potentially permanent consequences. Psychologic sequelae such as PTSD, cognitive impairment, physical complications such as respiratory impairment, prolonged mechanical ventilation and disability, and increased mortality. In patients with substance use disorders, one or more of these conditions are often pre-existing and amplify the consequences of delirium and its subsequent morbidity and mortality risk. And I wish I had more time to discuss the individual management of overdose and withdrawal of every recreational substance that you're going to encounter in this population. In place of that, I've linked a great review of that very topic right here. I encourage all of you to download this paper and save it for your reference. I promise you, you will use it. Hey, the phones are out. It's working. For now, let's dive into one of the highest yield topics that I've encountered in the critical care setting, which is appropriate pain management in patients with opiate use disorder, especially in patients who are already receiving opiate agonist therapy in the outpatient setting. Acute pain, especially pain related to trauma, procedures, and surgical procedures, are common in all of our critically ill patients. Patients with opiate use disorder also experience acute pain, but their management is complicated by provider misconceptions, opiate tolerance, decreased pain threshold, and provider confusion about how to manage their pain while on concurrent opiate agonist therapy. None of us are impervious to bias and misconceptions, but these common misunderstandings impact patient care and lead to untreated pain, withdrawal, agitation, and ultimately delirium, and all of its associated morbidity and mortality risk. Common misconceptions include the concern that the medication used for opiate use disorder should cover the acute painful condition, that the use of opiates for analgesia may result in return to active drug use, that the addition of opiate analgesia to opiate maintenance is likely to result in dangerous CNS and respiratory depression, and mistrust that complaints of pain are actually drug-seeking behavior. So let's do some debunking together. Myth 1, medication used for opiate use disorder should cover the acute painful condition. Patients receiving maintenance therapy with opiates for addiction treatment do not derive sustained analgesia from it. Though methadone and buprenorphine are potent analgesics, their analgesic properties are much shorter in duration. It's about 4 to 8 hours depending, which is substantially shorter than their suppression of opiate withdrawal, which is closer to 24 to 48 hours. Because most patients receiving opiate agonist therapy are only given a dose every 24 to 48 hours, the period of even partial pain relief with these medications is relatively small. Myth number 2, use of opiates for analgesia may result in return to active drug use. There's no evidence that exposure to opiate analgesics in the presence of acute pain increases the rate of return to use in this population. A small retrospective study of patients enrolled in maintenance methadone programs who received opioid analgesics for surgery did not find a difference in return to use indicators when compared to matched patients receiving maintenance methadone alone. In fact, return to use prevention theory suggests that the stress associated with unrelieved pain is more likely to trigger return to use than adequate analgesia. Patients receiving opiate agonist therapy have stated that pain played a substantial role in their initiating and continuing drug use. So in other words, if you appropriately treat patients' pain, even if it requires opiates, you could be preventing return to use. Myth number 3, addition of opioid analgesia with opiate agonist therapy will cause dangerous levels of CNS and respiratory depression. This is a theoretical risk, but it's never been clinically demonstrated if patients are maintained on their home dose of opiate agonist therapy. These patients will rapidly develop tolerance to the respiratory and CNS effects of their home doses of methadone and buprenorphine. That means they will likely require more and not less than the anticipated additional opiates before they have noticeable respiratory and CNS depression. Myth number 4, complaints of pain may constitute drug-seeking behavior. Concerns about being manipulated is difficult to quantify. It's emotion-laden, regardless of whether the patient is currently receiving opiate agonist therapy. After thorough history, physical exam, and other diagnostics, reports of acute pain with objective findings are less likely to be manipulative gestures than reports of chronic pain with vague presentations. And furthermore, patients who are receiving opiate agonist therapy typically receive treatment doses that block most euphoric effects of co-administered opiates. So theoretically, for what it's worth, this decreases the likelihood of opioid analgesic abuse. So what should we do to appropriately treat pain in patients who are already on opiate agonist therapy? In general, patients should be maintained on the medication to treat the opiate use disorder and then supplemented with short-acting opiates titrated to pain relief. Try to use opiates with higher binding affinity to the mu receptor, such as hydrochloromorphone, fentanyl, and oxycodone, as opposed to morphine. In ICU patients, physiologic responses such as heart rate and blood pressure may have to be used to monitor pain relief, especially those maintained on sedation and mechanical ventilation. And it should be recognized that patients with a history of opiate use disorder will likely exhibit tolerance to opiate medications and may require higher than usual doses to treat pain. Treatment of acute pain in patients maintained on buprenorphine for opiate dependence may be especially challenging because this medication has higher affinity for the mu receptor than other opiates. For these patients, there are several options to appropriately treat their pain and discomfort. The best option is still to continue their daily buprenorphine dosing with the addition of short-acting opiates, even if the patient is going for surgery. You can also transition to methadone, which has a lower affinity for the receptor, with addition of opiates to treat pain. You can divide the buprenorphine from once daily to 3 to 4 times daily, which will take advantage of its analgesic properties. And as an absolute last resort, you can stop their buprenorphine while admitted to the ICU and transition to full dose opiates for treatment of pain, but the strategy is not recommended for routine management of these patients. If you're considering any of the last 3 options, please concurrently call our addiction medicine colleagues, and they're always happy to talk to us about the more nuanced cases. Let's talk about our patients who are not already engaged with treatment for their substance use disorder. Regardless of why this patient is in the ICU, whether they were admitted for treatment of overdose, complex withdrawal, or sequela of their substance use, or a combination of all of these, intensivists meet these patients at a critical time, and our practice patterns offer unique perspective in this population's care and an opportunity to build trust and rapport with a medical system where this population frequently feels overlooked or judged. I won't belabor this point for very long. We've all taken step 1 and step 2 before, but quick refresher, methadone is a full agonist with high intrinsic activity on the mu opioid receptor. It also acts as an NMDA receptor antagonist that might be part of its ability to reduce drug cravings. Buprenorphine is a high affinity partial agonist with low intrinsic activity. Because it's a partial agonist, it has a ceiling effect on the receptor activity, and so after ingesting a modest dose, further doses do not increase the effects and thus decrease the risk of respiratory depression and overdose. Both prevent withdrawal and reduce cravings through their opioid agonist activity. A collective goal for all of us treating these patients is to reduce their mortality risk and increase their quality of life in the face of devastating disease. Nothing does the job quite like opiate agonist therapy. Some patients may be able to achieve complete abstinence from all opioid agonists. However, this population frequently experiences permanent changes to the reward center of their frontal lobe, making restoring homeostasis without medication exceedingly difficult, even if they've undergone detox. Massachusetts researchers identified almost 18,000 cases of adults who survived an overdose between 2012 and 2014. In the 12 months following overdose, only 34% of individuals received any medication for opiate use disorder. In patients who did receive medication, there was a 59% reduction in all-cause mortality for individuals taking methadone compared to those not taking medication, and a 38% reduction in all-cause mortality for those treated with buprenorphine. There was no change in mortality associated with naltrexone. A 2017 meta-analysis replicated these results and found that these patients also have decreased transmission of hepatitis C, HIV, decreased criminal activity, decreased opiate use, increased social functioning. With these incredible gains in mortality and quality of life, we need to seize every opportunity we can to identify these patients, meet them where they are, and offer them opiate agonist therapy. I wanted to take a moment to highlight a program that our own emergency department uses to take this belief very seriously. Yale Emergency Medicine has an ED-initiated buprenorphine program. Flow sheets, little bit outdated because the waiver is no longer required to prescribe outpatient buprenorphine, but the rest still works. So buprenorphine is dosed on an average about 8 milligrams per day, and it provides a predictable withdrawal management pattern, which makes it the ideal medication for hospital and ED-initiated opiate agonist therapy. It can also be prescribed to community pharmacies as opposed to methadone, which must be ordered and dispensed by an opiate treatment program. Since buprenorphine has high affinity for the mu receptor, it will displace any other opiate on the receptor and can therefore precipitate withdrawal. This methodology requires dosing buprenorphine while a patient is in withdrawal as measured by COWS. There are some nuances in the age of widespread long-acting and high receptor affinity opiates, such as fentanyl, but in general, patients will be in withdrawal 12 hours after last heroin use, 24 hours after oxycodone. Methadone is going to be closer to 48 to 72 hours. There should be a major improvement in withdrawal symptoms about 20 to 30 minutes after initial dosing. Here's another QR code. This will link directly to the ED's website for this program for a much more in-depth explanation on it. Many patients will be taking benzodiazepines and other substances along with their opiates, and this is not a reason to withhold treatment. Co-use is suspected and when co-use is suspected, patients are counseled on higher risk of overdose when other sedatives are on board. And hopefully I would have actually looked to make sure that this worked correctly, but I didn't. There's the thing that was supposed to pop up. Patients who are initiated in this program don't need routine blood work. There's no mandatory tests needed if you're sure that the patient has opiate use disorder. A pregnancy test might be helpful in terms of referral and deciding on whether or not to administer or prescribe buprenorphine with or without naloxone. If there is concern regarding methadone use, you can check a urine sample, but typically methadone can be in the urine for much longer periods of time. Buprenorphine is metabolized in the liver, and it may be a problem if the LFTs are greater than 5 times than normal. However, obtaining them is not essential for the first visit, though might be helpful for the receiving referral site. You can also get hepatitis C and HIV, but this can also be done at the referral site. And as it turns out, this approach works. A study based out of 7 emergency departments in California from April 2021 to June 2022, as part of a statewide initiative to increase buprenorphine access, found that 50% of patients initiated on buprenorphine in the ED continued their opiate use disorder treatment 1 month after induction. So as I alluded to previously, in 2023, the requirement to obtain a waiver in order to prescribe outpatient buprenorphine was dismissed. Although it was never a problem for administering in the hospital, but that's all bygones be bygones now. Direct discharge from the ICU is more common in patients with substance use disorders than other patient groups. So this represents a key opportunity for us to broaden our scope of practice and initiate and prescribe opiate agonist therapy to patients with opiate use disorder in ICU settings and try to replicate the success that our emergency medicine colleagues have found. In addition to connecting these patients with treatment and outpatient resources, overdose prevention efforts have to be prioritized. High-potency synthetic opiates are becoming more common now more than ever, such as fentanyl, and we must prevent overdoses. All patients with direct discharges from the ICU should leave with a prescription with naloxone. This small but growing body of evidence supporting hospital and emergency department initiation of buprenorphine for treatment of opiate use disorder has now expanded to the critical care setting. In this study, patients with standard induction underwent an 8 to 12 hour washout period prior to buprenorphine initiation. All 57 patients who underwent standard induction completed it, and only 1 patient experienced withdrawal symptoms. Low-dose inductions were chosen for patients who would not be able to sustain a washout period. For example, people requiring a fentanyl drip or frequent opiate administration for pain. Of the 29 patients who started low-dose induction, only 3 patients declined further buprenorphine and none experienced withdrawal. So let's take a second to go over some common questions and concerns that providers new to hospital-initiated buprenorphine have. How long do I need to wait to initiate buprenorphine after naloxone reversal? About 2 hours, then perform the COWS, treat accordingly. How many days of buprenorphine prescription should I prescribe? There can be some difficulty in reaching a referral center, and so you can prescribe up to 7 days worth of buprenorphine. What's the worst thing that can happen after I administer buprenorphine? The patient, if they have other opiates on board, they can go into withdrawal. Should I worry about diversion? Diversion of buprenorphine actually occurs less frequently than with other opiates, and individuals who are obtaining it illicitly almost always are doing it to try to reduce withdrawal, which means that every time there's one less use of injection drugs, that's one less opportunity for overdose and death. Now let's take a detour and talk about the effect of stigma and bias that these patients face. The WHO conducted a study in 14 countries to examine the relative stigma associated with some of the most stigmatizing conditions: homelessness, being HIV positive, having a criminal record. They reported that drug use was ranked the most stigmatized condition, and alcohol use was the fourth. A large body of research indicates that stigma is rooted in the belief that addiction is a personal choice, reflecting a lack of willpower and a moral failing. This matters because stigma surrounding substance use disorder is one of the major barriers to individuals seeking treatment. And the language we use matters. A study out of Mass General distributed case vignettes of over 700 mental health care providers at a conference about addiction. The vignettes tell a word-for-word identical story about Mr. Williams, who is in court-ordered treatment for addiction and is waiting for a judge to determine his status after he failed 2 urine drug screens and a breathalyzer test. The only difference between the two cases is one case described him as a substance abuser, while the other said that he had substance use disorder. Those assigned the substance abuser term were significantly more in agreement with the notion that the character was personally culpable for his condition and more likely to agree that punitive measures should be taken. Those participants were also less likely to agree with the notion that a substance abuser needed treatment as compared to a person with a substance use disorder. An underestimated mode of stigma transmission is the medical record. How we describe this patient population's substance use disorder and behavior can have profound impact on how anyone else with access to their chart will treat them going forward. Our documentation especially impacts trainees and how they view their own patients. A study evaluating the impact of the medical record and stigma on medical students and trainees found that stigmatizing language used in medical records to describe patients increases the risk of subsequent physicians in training reporting negative feelings towards their patients, such as feeling that the patient is a threat. This effect was amplified as trainee level increased, possibly from compounding observed negative attitudes and behaviors among their peers and seniors in the clinical setting. The trainees were then less likely to treat a patient's pain as aggressively as someone with neutral descriptive language in their medical record. There are hard consequences for the implicit biases that we hold and pass on. Health professionals are more avoidant to patients with substance use disorders compared to other patients, meaning they make shorter visits, show less empathy, and have diminished personal engagement or outright delegate care to personnel who lack knowledge and adequate training when caring for these patients. This can lead to suboptimal healthcare delivery due to more task-oriented approaches of the health professionals when working with this population. There's also unfortunate cases where quality of care may be intentionally compromised by increasing patient wait times or delaying interventions, and therefore, obviously, receiving suboptimal care. Our individual and collective treatment of this patient population can have damaging and devastating long-term consequences. Patients with substance use disorders are at an increased risk of a task-oriented healthcare and undertreated pain and other symptoms. Informing this behavior is healthcare workers' misperception that patients dependent on opiates are demanding when they are hospitalized with acute pain. This scenario develops in part because of the patient's distrust in the medical community, concern about being stigmatized, and fears that their pain will be undertreated or that their opiate agonist therapy will be altered or discontinued. Patient anxiety related to these concerns, which can be very high and very well founded, complicates the patient-provider relationship and provision of adequate pain relief. This dynamic results in poor hospital experience, including increased length of stay and delirium, both of which carry a significant morbidity and mortality risk. This population is also more likely to ask for patient-directed discharge, and patients who opt for patient-directed discharge are ultimately less likely to seek treatment for their substance use disorder. All of this compounds into decreased trust in the medical system and decreased engagement in treatment for both routine medical care and substance use, and overall increased morbidity and mortality. To put a finer point on this, In addition to financial costs and the person's geographic location, stigma is the leading reason why people with substance use disorders do not seek or receive medical attention or substance use treatment. Given that patients obtaining treatment for their substance use disorders has an enormous mortality benefit, finding ways to reduce stigma is not just the right thing to do as a human being, it is potentially life-saving. People with substance use disorders frequently feel written off or abandoned by healthcare staff and experience shame that their current or past substance use. People who inject drugs describe being mistreated, dehumanized, and receiving decreased quality of care. Inevitably, people with substance use disorders internalize the stigma and often refuse to return to care despite potentially severe health consequences. Strategies used by people with substance use disorders to avoid experiencing stigma in the healthcare setting include delaying care and not disclosing their substance use. When internalized stigma results in painful social isolation, and this further exacerbates their underlying disease. We have the power to stop this cycle, combat bias, and improve care and outcomes for this population. Good news is, as intensivists, we already are intimately familiar with some of the concepts and behaviors that are proven to improve care for patients with substance use disorders. For example, primary palliative care is essential to ICU practice, and these principles in the ICU can naturally be expanded to advance hospital-based substance use care. This Venn diagram shows overlapping palliative care and substance use disorder treatment strategies. This should be familiar to us. It includes effective communication, diverse team-based care, addressing social determinants of health, focusing on patient goals of care and quality of life, and adhering to ethical principles. So we already have the foundation, and now we're going to build on that. Let's talk about drug urine screens. These tests are, in my opinion, a hotbed of bias generation. A urine drug screening is an immunoassay. It's looking for a chemical structure. Similar structures can trigger positive results. The graphic shows just a taste of all of the commonly used medications that can trigger a false positive on a urine drug screen. And these tests are frequently taken after substances such as opiates or benzodiazepines are given in the hospital, yielding positive results that are absolutely meaningless. Even if the urine drug screen accurately represents drug use, this does not automatically qualify someone as a person with a substance use disorder if they don't meet the other DSM-5 criteria. I tell my residents all the time, a patient with a positive urine drug screen might just like to party differently than the rest of us. So when it comes to urine drug screens, please proceed with caution. If the results genuinely will not change your management, or the patient has already received opiates or benzodiazepines while they've been hospitalized, consider foregoing it altogether. As I have hammered on, the language we use and where we use it matters. Stigma-free, person-first, and patient-centered language, altogether known as compassionate language, is key. The goal is to recognize these patients as human beings separate from the disease of addiction and acknowledge their individual circumstances. Compassionate language, in addition to combating internal and external biases, stigma, and its downstream consequences, is actually more accurate, science-based, and helpful to our colleagues who are working to optimize the patient's care. Avoid language that suggests that substance use is a choice or a moral failing, and instead use neutral, medically and contextually accurate terminology when describing the substance use. You can see in this graphic really easy places to start. If you obtain a urine drug screen, refer to it as positive or negative for specific substances and avoid referring to it as clean or dirty, because unless there's mud in the urine sample, I promise you it's not dirty. Beyond transitioning your language from drug addiction to substance use, if a patient uses multiple substances, avoid falling into the trap of writing in or copying forward the term polysubstance use in the patient's one-liner. It will take more time and chart digging, but please instead list every individual diagnosis as accurately as possible. The term polysubstance is non-specific, does not provide accurate or useful information, and just increases stigma. And please be mindful of where you are when you're speaking about the patient. Patients with substance use disorder frequently overhear the medical team speaking about them, and stigmatizing language is a great way to destroy your relationship with them. We know at this point that what we put in the chart can impact the patient long term. A very familiar concept is the discharge against medical advice. And you all probably noticed that instead, I have been using the term patient-directed discharge. It's more patient-centered language. This is because AMA is actually a term that doesn't confer any legal liability coverage to us as a discharging physicians. It risks escalating a potentially already tense situation, especially when the AMA form comes out, and it leads to further stigmatization of patients who are from very vulnerable groups. The NIH's National Institute on Drug Abuse, despite its unfortunate and outdated name, is a fantastic resource for all things compassionate language. Something important for all of us to keep in mind is that language is always updating and evolving. For example, when I was preparing for this talk, I learned that we no longer use the term relapse. We actually now say return to active drug use. We will not always get the best practice language right, but as long as we remain open to learning and changing, we can immensely positively impact people long term. In fact, analysis of discharge summaries showed that the best practice language was uncommon, but when it was used, it was associated with increased odds of substance use treatment and specialty care referrals for this population. And as we have discussed ad nauseum up to this point, increased substance use treatment comes with improved quality of life and mortality. Person-first language is critical in all aspects of healthcare, but especially patients with substance use disorders. We're not defined by what we put in our bodies, but rather how we interact with the world. The QR code will take you to the NIH's website for full guidance on non-stigmatizing language. Other best practices. Avoid emphasizing the legality of particular substances or contexts of use to encourage behavior change. Individuals who use illegal substances are generally aware of the possible legal consequences of their substance use. Treating substances as a criminal issue in a health context may foster fear of these consequences, distrust and avoidance of health settings, and among other things when it related to their substance use. Also, one of the defining criteria of substance use disorder is use despite consequences. If legality truly could stop the use disorder, it would be a dependence, not an addiction. Some people with substance use disorders do not identify with or endorse the term disorder for various reasons. We have to respect the right of individuals with lived and living experience to refer to themselves using language that might otherwise be considered stigmatizing. We've probably all heard the word junkie thrown around. We have to recognize that these types of self-labels reflect internalized self-stigma. The use of these self-labels doesn't give us permission to adopt similar labels or make it okay to correct someone for how they self-identify. So friends, let's bring this talk home. And if you take anything away from today, I really, really hope it's these 7 things. Substance use disorder is a complex disease that includes impaired control, physical dependence, social problems, and risky use. Address withdrawal and pain early and adequately in order to reduce morbidity and mortality. Opiate agonists such as methadone and buprenorphine save lives. When in doubt, please continue the patient's opiate agonist therapy, and if you're worried that you can't, please call our friends in addiction medicine. Buprenorphine initiation is in your scope of practice, and it will increase outpatient treatment engagement. Stigma and bias set up a cascade of events that will ultimately lead to worse outcomes and increased mortality. Use compassionate language and stay patient-centered. If you do, I guarantee you will save lives. So friends, I'm going to end with a quote from the great Ted Lasso, one of the best pop culture examples of compassionate language. Be curious, not judgmental. Promise is the last QR code for anyone who's interested in my references. And to my thank yous, I have so many people who I want to thank. Dr. Mathey for organizing Grand Rounds, department leadership, Dr. Kaminsky and Dr. Seiner, my program leadership, Drs. Hunniden, Clark, Lozier, and Koff, my mentor for this talk, Dr. Donrow, my thesis mentors, Dr. Chitra and Lou, my co-fellows, especially my 3rd-year fellows. I'm including you, Elizabeth. I don't know if you're here, but you're one of us. I don't care what anyone else says. My lovely husband pictured all the way on the right. And my little gremlin helpers, Gizmo and Gimli. I'll take any questions.
Maddie, thank you so much. That was an amazing talk and just hit so many high yield topics that we see day in and day out in the ICE. Thank you. That was incredibly helpful. I'll start out as we pass along the microphone. I think one of the things I was really interested in and have always sort of considered is the time that we engage with patients in the ICU. How good of an opportunity is it to initiate things like medication for opioid use disorder, have those conversations, particularly because so many are not on those therapies when they come into the ICU. I'm so happy to see that now there's a little bit of literature at least on doing so. I was wondering if we know if this is a particularly effective time after a potentially life-threatening event that might be a really important time to intervene with it.
In theory, yes. In my rabbit hole in looking this up, I couldn't find any data, but that's because ICU-initiated buprenorphine is so new. So we don't have long-term consequences. And so all of my thinking is extrapolated from the success from the emergency department initiated medication, but it does seem to be having success.
So Maddie, thank you for a phenomenal talk. I wanted to highlight a couple of things. One is I think we have actually come a long way in terms of managing these patients, and actually many of the points that you highlighted in terms of patient-centered care and using the addiction medicine service has made a huge difference. One area that I think we still have an opportunity to work on is actually more sophisticated management of severe acute pain in this patient population, and I'm still sort of struggling to know who is going to be there helping us. We had a patient recently who had very severe acute pancreatitis who was on methadone prior to coming in, and so managing the methadone, the acute narcotics, and still achieving pain control was challenging because I think she also had some degree of opiate tolerance. And I think that the addiction medicine service turned out to be very helpful in terms of tweaking the methadone, which we ended up using as a supplemental way to provide analgesia. But the other thing that I thought was really helpful was adding adjunct therapies. So non-steroidals, acetaminophen, we even got like integrative medicine.
Use NSAIDs at the MICU?
Step down unit, maybe it's okay over there. But her renal function was normal, but those Toradol injections were very helpful.
So well, I just never have patients who can take them.
Yeah. So anyway, I think that we also got the anesthesia pain service involved. So just I think the sort of like multidisciplinary care, which I think you're getting at, is another good area to keep in mind.
Absolutely. Especially if a patient's already on opiate agonist therapy and familiar to our service, calling our addiction medicine colleagues is always welcome. They just might be tired because we call them a lot.
We're happy for the calls. I will say this here, there's often
Thanks.
There's often consults to us regarding pain and pain management, and to your point, it's extremely important. There's two services I think that sort of take this on. One is us, the addiction consult service, and the other is the acute pain service run by anesthesiology. And generally the breakdown has been if the patient has an underlying substance use disorder, we take on the pain piece as well as managing the substance use disorder. And if they don't have an underlying substance use disorder, acute pain service will help with the pain management. But oftentimes there's a lot of shady area, like there's a lot of gray there, and trying to figure out, is there an underlying substance use disorder? So sometimes both teams are involved initially, and we work together to figure out, where our lane's going to be and how are we going to help each other to make sure that we're doing the best care for the patient. But we're very happy to see the patients you refer to us.
It's an incredibly helpful service. Just while we're transitioning, Maddie, I want, one of my favorite new expressions, by the way, is absence of evidence doesn't mean evidence of absence. And I think in conversations we've had with our critical care colleague, Dr. Buckley, there really is a paucity of evidence for a lot of things that we do related to substance use disorder in the ICU. And I think one of the points that you addressed was this issue of, and I think you were emphasizing, continuing to maintain the home dose of MOUD while patients are in the ICU.
Mhm.
Is there data on that, or about the safety of doing so? Because I think routinely we do not do that as current practice.
I think that's what comes, we get concerned that if we add additional opioid analgesics, or if we just continue someone's opioid agonist therapy in the acute setting, we will cause more harm than good. Typically, continuing their opioid agonist therapy won't cause, especially if it's at their home dose, and we've confirmed that, won't cause new levels of CNS depression or respiratory depression, especially if it's buprenorphine. Buprenorphine is considered to have an exceptional safety profile.
Thank you, Maddie. That was awesome. A lot of actionable things for us to, I think, continue or start doing. I had a question because I think you may have touched on this, and I may have a misconception that you can clarify. So I was under the impression that apparently is incorrect, that because buprenorphine is a strongly binding partial agonist, that if I were to continue someone's buprenorphine while they were, say, intubated and needed pain control, pain management for their acute ICU indication, that continuing the buprenorphine would blunt my ability to appropriately treat their pain with, say, like fentanyl pushes.
Hmm.
Sounds like that's not necessarily true. Can you elaborate on that?
Basically covered it. Continue their maintenance therapy, and instead of using something like morphine, which will definitely have a weaker binding capacity, if you use things like fentanyl, especially fentanyl has a very high binding capacity. Hydromorphone's another great option, or oxycodone if you're switching to orals. You should be able to get enough analgesia to appropriately manage the pain. You just might need to be comfortable with how high a dose you need. Exactly.
Okay, so just crank up the dose as needed, continue the buprenorphine, and don't blink.
Yes, and call our addiction medicine colleagues, who will also help us and reassure us that we're not going to kill someone.
Awesome, thank you.
Just address the question to you or your colleague with the addiction center. What is the long-term natural course of this substance use disorder? What are the epidemiological data? I saw a paper in the New York. A woman who's actually a psychologist working at a, she managed to be totally off the drug for a long, long time. So maybe a comment about that.
Yeah. Some people, so you're talking about complete abstinence from all opioid agonists. Some people are able to do that. It's difficult because over a period of time, if you've used opioids, you've actually rewired your frontal lobe in the reward center, and it becomes dependent on the opioid agonism in order to maintain homeostasis. So you're not even achieving euphoria anymore, you're just maintaining homeostasis. If you come off it, even if you've come through the withdrawal in and of itself, you still can have the cravings and you still won't be able to achieve the homeostasis. And that's where opioid agonist therapy comes in. And so that's how you get the benefit of long-term opioid agonist therapy. It allows people to feel normal again without the devastating consequences of their use disorder.
Yeah, I can maybe add a little bit too. I think when we think about the long-term outcomes for people with substance use disorders in general, recovery is the rule, not the exception. So our patients do very well. Sometimes our perspective on this gets skewed in the hospital setting because we see that really horrible combination of substance use disorder and mental health and homelessness, and we sort of generalize that to saying, well, this must be the norm because that's what I'm seeing mostly. But most of our patients go on to recovery. They have productive lives, and it's a wonderful patient population to care for because most of our patients are actually quite young, and go on to finish school and have families and have jobs afterwards. And so it is a chronic disease. It's their need for remaining on opioid agonist therapy is variable. I would say most people end up coming off of opioid agonist therapy, although for some people it's a medication that they need to be on for a long, long time, just like their hypertension medications. But recovery is the rule, not the exception. And then a quick comment about the buprenorphine question. I tell my fellows in addiction medicine, so we probably know less about the mu receptor than we think we do. And so we used to think that you had to stop the buprenorphine and we couldn't manage pain, or we couldn't send patients to surgeries if they're still on their buprenorphine. And what we found was that people would return to use afterwards because we stopped their chronic opioid medication. Pain became much harder to manage because we were taking away their medication that gave them their tolerance, and now that's gone. We have to make that up with short-acting opioids. And so what we found is the more we keep people on their buprenorphine, actually the less opioids we need to manage their pain in the short run when they have short-term pain. And we were also able to manage people safely during surgeries as well on maintaining them on buprenorphine. And there's less return to use afterwards because they've been maintained on their life-saving opioid agonist therapy. So it's become the standard of practice. It's what we push, and there are a few exceptions to that. Sometimes they're there, but for the most case, default to maintain the buprenorphine.
Great. Other questions? I'm almost a little nervous to ask, how are we doing with our PIC policy at Yale New Haven Hospital?
I haven't come across it yet because I haven't had to discharge someone from the ICU with one, thank God.
Do we know the answer to that?
I don't know that there's I know we get consulted on the question a
Yes.
lot, so there's not a policy that I'm aware of that prevents patients with substance use disorders from leaving the hospital. I think to Maddie's point, being individualizing our approach to deciding, have I done everything to safely discharge this patient, really makes a lot of sense. And when I think about it from the perspective of substance use disorder, I'm thinking about, does this person have a home to go to? Are they suffering from mental health conditions that would make it dangerous for them to have a PIC line? Is this a person who's in remission with their substance use disorder, like the case with Maddie? And most of the patients we find can actually leave with their PIC line, which makes a huge difference for patients and for the hospital.
Just so people can hear you, sure.
I tried to find it actually so that I just say it, but maybe you have seen it. There is a question that came up with an interesting one. We had a patient on buprenorphine and hypercarbia, right?
Mhm.
So has hypercarbia, I think had bronchiolitis. And from what I remember, there was a review in England Journal about the effects of buprenorphine and methadone. And if I remember correctly, methadone affected the center even less than buprenorphine. So we were treating her for hypercarbia, and she had some symptoms of withdrawal, even like the sleep cycle, all that. So did you see the effect on hypercarbia? Which of them is less, or is it okay to just continue? So if you have a patient on buprenorphine in the ICU for hypercarbia, is it okay to continue or not, or change
Okay, so the patient on the outpatient end is already on methadone?
and now it's in the ICU. Yeah.
Okay, so the question is the patient with baseline hypercarbia or acute hypercarbia?
Well,
Acute on chronic?
there is both components, like a COPD.
Yeah, so a patient with baseline hypercarbia is admitted to the ICU with acute on chronic hypercarbic respiratory failure and is on methadone on the outpatient setting. Is it safe to continue the methadone? And my understanding is that they should be tolerant to the effect of that specific dose of their methadone, so it should be okay to continue it, but that's a little bit more nuanced, and I probably would still call addiction medicine to help me out in that specific case.
Yeah, so if you wanted to, I know that morphine affects it. So we know that morphine affects hypercarbia. But in that review, was maybe 4 or 5 years ago, it was saying that methadone and buprenorphine, they do not affect the respiratory center as much as.
Yeah,
as
buprenorphine should affect the respiratory
should be.
drive because of its partial agonist activity. It has a ceiling effect. So
Yes.
addition of additional buprenorphine should not depress the respiratory drive any further.
Yeah. That's what I.
Yeah, I mean, I think we get that consult not infrequently. Patient on methadone who's hypercarbic. What should we do? And you know, the approach is going to be to individualize it to the patient. In theory, the tolerance to the respiratory depressant piece of opioid use on methadone or buprenorphine, especially methadone, should diminish over time. In other words, there should be less of a hypercarbic effect the longer they're on their methadone. That being said, physiology changes. Patients get older, their kidneys start to fail, their liver is going down, new medications get added. So, you know, I think if you have a patient who's struggling with hypercarbia in the ICU and they're on methadone, then it's reasonable to start having conversations like, should we come down on their methadone? If this is a chronic hypercarbic situation, can we talk to our patient about switching to buprenorphine, which we know is going to be a safer alternative? And we have those conversations with patients, explain the rationale, and often they're eager to get behind it. For the most part, patients really, well, this is going to be a generalization, but buprenorphine is a lot easier for patients to take anyway, and so they're often looking to make that switch. But the conversation is really important to have.
And there, thank you for.